ahead. Okay. Hi, everybody. Thank you for joining us for a PTech seminar. Today, we have the pleasure of welcoming Paul Umbach to our monthly PTech series. Paul is the founder and president of the Tripp Umbach consulting firm. Since 1990, Paul has consulted with more than 1,000 of the nation's most prestigious organizations. He's completed more than 500 impact assessment projects for clients such as the Association of the American Medical Colleges, the Mayo Clinic, and the Council of Boston Teaching Hospitals. Paul is a pioneer in the national health community movement, having completed community assessments and health improvement plans in more than 500 communities over the past 30 years. More than 1 in 5 Americans live in a community where Tripp Umbach has conducted research and health improvement strategies. Paul is actively engaged in developing innovative tools that connect population health and economic development. He has consulted for more than half of all medical schools, as well as, half of all US medical schools, as well as graduate medical education expansion programs throughout the United States. More than 30 new or expanded medical schools have been opened in the past 20 years through the work of Tripp Umbach. That's very impressive. Paul is a published author and a graduate of Harvard University. He also holds a Master of Arts from the University of Akron. In addition, Paul is currently completing a Doctor of Education in Leadership and Learning at Vanderbilt University. Thank you so much for being here, and I'll turn the screen over to you.
Okay, thank you very much, Jennifer, and nice to meet everybody on this beautiful spring day here. I want to share just a few slides with everybody. Where do I even start? I think where we start is where we are, and that is that we're in 2021, and after the year of 2020, there's a lot of reflecting on COVID, but also a lot of reflecting on health disparities, racial justice, and what almost seems to be insurmountable issues. And one of the things that I want to offer to the group is a mindset, which I call economic design thinking, which is a way of really changing the world, making the impossible possible through really a different perspective on the economic design that kind of got us to where we are. And I just have a few slides, and then we're going to open it up for questions from the panel, and I hope this will be helpful. And I can give my information at the end if you want to reach out to me. As was mentioned, what's not on this screen is that I grew up in St. Louis, Missouri, in an urban area, and my dad was a professor at a historically Black college in St. Louis, and I went to Nebraska to study to be a Lutheran minister on a cello performance scholarship, and became very interested in geography. So I'm actually a professional geographer. So I don't come from a medical or a technology background. I come from a social ministry and geography background. And the other thing that's not on this screen is that I'm very passionate about changing the world. And I still believe that's a distinct possibility, but I now realize that there are many challenges that require a whole different way of thinking. One thing I just want to start with is that we already learned what we already knew during the pandemic, and the racial disparities in the care for people, and then also in the death rates were quite stark. And when you look at the data, these were data from kind of midstream in September, and they didn't really change much, but white folks definitely, as percentage of population, were sick and died at a much lower rate than Black and brown Americans. And I brought this quote in that health inequity is the most shocking and most inhumane form of inequality, from Dr. King. I grew up in the 1960s and early 70s in St. Louis, so my whole life has been really tied to this. And this year, I turned the age where the average African-American male would not be alive. So I've now gotten to the age of if I was a Black male, I would probably be half of the people my age are no longer alive. And in my neighborhood in Kansas City, if I walk 1 mile, life expectancy goes down 15 years just along 55th Street. And I took that drive this morning as I prepared. So there are stark differences in the health and wealth equity of Americans. And as we know that health and wealth are tied, and I look at the median net worth by age of households, and I see that Black Americans really never really achieve the wealth and that white Americans do, and this real disparity between health status and economic status is just starting to be understood by people, and it's starting to be seen that the social determinants, largely based on our wealth and our have so much to do with our health. And one last thought I want to share with the group as I get ready for my comments is that it's kind of interesting. I put the word finally here, that the CDC has now declared that racism is a serious public health threat. And racism actually not only a public health threat, but I think it's been embedded so much into our culture and our economic system. And I'm not just talking predatory lending. I'm talking the economics of healthcare and the economic design of how we care for people. So where do we go from this? Where do we go from seeing this from a public health perspective? When I was at Harvard doing work 5 years ago, I came up with something called economic design thinking that I want to introduce to you today. And I wrote papers on this. I have a lot of information on this. I'll send it to you. A little hard to get your hand around it, but it really is a mindset movement to move money to societal issues. And obviously the steps are pretty easy. You need to know that there's a need, in this case, economic disparities and health disparities. You have to understand the system. I think we're getting there. I think we're starting to understand, what is causing so much disparity in health and wealth in our country, at the neighborhood level, at the society level, at the state level, and also to promote long-term economic benefits from investing today, and really starting to think about how we change the system really from a different view, a sacred economy, even a view of money and power and privilege in a very, very different way. So economic design thinking is a way of maybe unlocking some of this. So I wanted to give this as like a preview as I answer some of the questions about what I think is the future of dealing with economic and health disparities. I come at this really from a social ministry perspective. I come at that from a geography perspective. I come from a healthcare perspective. I've worked in 500 communities around the world. I come at it from a perspective of a person who wants to change the world. So we come to a lot of perspectives. So I'm going to turn it over to my new friend, Serena, and she's going to ask me some questions. And Jennifer and Kirsten, jump in with questions if you want. So let's go from there. I'm going to get out of the screen. I'm going to show that I'm a consultant that doesn't have to have PowerPoint, that I will put myself on the screen in front of everybody. Let me see if I can get rid of that. And here we go. We're on the screen, free from the power of PowerPoint. Serena, I'm all yours.
All right. So, thank you for that presentation. I think that's, again, we had a demographer on yesterday recording, so it's really great to have a, geographer on today. And the first thing I'm thinking is what you mentioned, you consulted with the Boston teaching hospitals on their community health needs assessments, right? So when I was in social work school, that's actually something I looked at as one of my leadership projects, was how those hospitals, and I looked at their individual ones, and I think they eventually decided to band together,
Yeah.
but how they approached the idea of interacting with the community and how they thought of themselves as benefiting the community. And it was really interesting to see how the different hospitals had these different approaches to what they thought their importance was in the community and what they could provide. But I think a lot of people don't really know that the Affordable Care Act required hospitals to do that, to assess the community health needs and how they could implement programs to address them.
Right.
So you've conducted a lot of these, right? So how do you think that your experience working with these hospitals and health systems on their community health needs assessments has influenced your idea of economic design thinking?
Great question. I think we got to go back to the beginning of the movement. Back in 1990, when we did our first community health assessments, and between 1990 and 2010, there was a very strong energy around community health assessment for the right reason. It was much more of a grassroots movement.
Mhm.
Hospitals were at the table, but we had all kinds of other community organizations, every kind of diverse representation at the table. And up until 2010, there was this sense that the community was kind of creating its own vision for health. And there was a lot of good, positive work that was done. And hospital CEOs would sometimes be in a minor position at the table, and the community grassroots leaderships were much more prominent. So when we started the Bronx Health Link and the Brooklyn Health Connection, and really programs all over the country, it was very much not a hospital-centric process. Fast forward to 2010, and the IRS, through the Affordable Care Act, came up with something which was called a mandate for every hospital to do a community health needs assessment. And that's where you see, if you look out there, these CHNAs that have been posted to websites, and every nonprofit hospital has had to do that. And I'm not saying that's been a bad thing, but it changed the direction significantly. And now hospitals, because they have this IRS 990 Schedule H mandate, are out there doing it because it's a mandate and it's a requirement, and they're following the thing. And our first client was the Cleveland Clinic in 2010, after this mandate was put in place. And our client wasn't good, God-fearing community people like we were used to working with. Our client was the legal department. And at the same time that we were doing the community health needs assessment, the legal department was really pushing us to make sure that we satisfied all the demands. And at the same time, they were closing Huron Hospital across the street, where there was the #1 rate of gunshot wounds, and it was the most under-resourced community hospital. And they were closing this hospital at a time to really take healthcare away from an African-American community that really was sorely in need of community health. And we were really struck by this juxtaposition between the IRS requirement, what was the right thing for the Cleveland Clinic to do. And if you then go around the country, you saw this disconnect between hospital systems now through this mandate, which continues to the day. There's been some change, and I think that the economic design of health is changing. I want to just tell the whole audience that why didn't we have hospitals want to keep people healthy? Well, because it wasn't economically very much in their interest to do that. As we start seeing a new payment model that recognizes and rewards quality and health status and wellness, we're seeing hospitals now shift. I wrote an op-ed that I want to send to everybody if you want to read it, which is sort of damning to healthcare, in that, wow, you're finally seeing that there's money to be made in keeping people healthy, especially minority communities and under-resourced communities. So now, aren't we great doing all this great work to help people be healthy? So I wanted to stop by saying that, yes, there is a mandate, but I've seen in my career, the first 20 years were a lot different than the last 10 years in terms of the motivation. And now that healthcare economic design is changing, we see more and more folks wanting to get involved with social determinants. We want to see people get involved. But I question the morality. I really question the morality of our healthcare system now waking up and saying we really care about the needs of the underserved communities and in folks with health disparities because now it's going to be economically good. So once again, a new economic mindset is necessary.
Yeah, so that's interesting. I'm thinking about, I spent 2 years in Boston, so Boston University. So I have a lot of experience looking at the Boston hospitals. And what's interesting is the different approaches that they took in terms of developing, these implementation plans on how to address the community health needs. You know, Boston Medical Center, which is a safety net hospital that serves a
Yeah.
really large, underserved, marginalized population. They started directing their resources towards building housing, to
Right.
addressing food insecurity, and what we kind of think of those really intrinsic social determinants of health. And
Right.
then if you look at a hospital like the one that I'm thinking of, which was the most notorious to me, was Boston Children's Hospital, which is super wealthy, world renowned, does a lot of research, and they kind of thought of that as their contribution to the community health needs. That we do, we get billions of dollars of research funding, and this is how we're, going to affect the community. And so it's interesting how when you think of this question of economic design, it's sort of how much is it penetrating these different health systems, these hospital administrators and leaders, and how, I guess, how, what is the timeline that do you think that we're going to really start getting into people investing in the more social and moral aspects of the community health needs assessments, and not just using them as a checklist of what they're required to keep their nonprofit status?
Yeah, I think you're bring up a real deep and very important point, and that is that it's not at an institutional level that we have change, be that government, be that healthcare institutions, be that bioscience and biopharma companies and industry. Behind all these institutions are people, and it really becomes a personal commitment. And the folks, the CEOs of the organizations that have done the most in community health are the people that are the most passionately connected to it. And you might say, well, I'm sure they're all at certain places that are in certain roles that are drawn that way, but it's not really true. In fact, there was Catholic hospitals that were run at one point by sisters. A famous sister coined the phrase "no margin, no mission." And I think what I found in studying that system and that organization, or if you even look at Catholic healthcare in America, they too have kind of gone the way of Rick Scott, who ran HCA, who told everybody that he was in the sick care industry. And if you can keep people sick enough and they don't die, HCA made a lot of money. They also defrauded the federal government. This gentleman went on not to go to jail, which he should have. He went on to go to be a governor of Florida. Now he's a U.S. senator. I think he's got blood on both hands, both in healthcare and also in government. So then you go into the individuals that have been the strongest critics of community health. And often they're the people that believe that people have in their own means the right to be healthy and wealthy, and that society doesn't really have a place in this. And that's countered by some of the people you've talked about that actually see that social determinants are good just for good, not just because there's economic benefit in that. So it's a big issue of good and evil, I think, a lot. And what I'm finding is happening on good news is that we're starting to get it away from the hospitals and the government, and it's starting to become much more grassroots. And I think that what this coalition that you have can do is inspire change that happens at the level where change can really be measurable and really be important long term. And so I can give you a lot of examples of that, but I feel that once we start shifting our mindset from, well, like Rick Scott said, we're in the business of making money on sick people. And guess what? The whole system was set up for that. So can you blame him? Now, you can blame him for stealing money from the federal government, not going to jail, but you can't blame him for playing the rules that were put out there, which was to, in a sense, benefit from sickness, especially with minority populations versus benefiting from health.
Yeah, it's interesting you say that. It's that